Good evening, dear college and dear doctor. Thanks for inviting me. My name is Dr. Marcio Cívico. It's a great pleasure and honor to be here. Today I'm going to talk you about an article titled Gender and Outcomes in Non-Small Cell Lung Cancer. Is a all prognostic variable returning for targeted therapy and immunotherapy? Next, please. Starting with the introduction, we have these four important points. And the first point, lung cancer is responsible for 1.6 million of deaths every year, where tobacco smoking is the main risk factor. The difference is response to treatment and outcomes could be related also to a differential distribution of clinical pathological features. For example, smoking status, histology, EGFR, mutations, and so on. As gender influence innate and adaptive immune response, immunological difference could be behind the difference in outcomes observed in some malignant disease. And the last point is some therapeutic strategies involve manipulating the immune system, while the immune system per se helps to model cancer evolution, determining difference in tumor aggressiveness and response to treatment. Next, please. Regarding the methods used, it is mainly based of meta-analysis, beginning with meta-analysis for gender difference in OS. We retrieve information from a 67 published record, of which 12 were eligible for data extraction. The next meta-analysis is for EGFR tyrosine kinase inhibitors. In total, 6 phase 3 clinical trials testing EGFR tyrosine kinase inhibitors, or TKI, versus chemotherapy in patients with NSCLC with the EGFR mutation were identified, evaluating gefitinib or erlotinib or afatinib. The next meta-analysis is for LK inhibitors. In total, 4 phase 3 randomized trials comparing ALK inhibitors versus chemotherapy in patients with NSCLC whose tumor-buried ALK regimens were identified and evaluated. 2 trials evaluated seritinib and crizotinib. 2 trials were in the first-line treatment or metastatic or recurrent NSCLC. 2 trials in second-line of treatment in patients who had received one prior platinum-based regimen or previously exposed to crizotinib and platinum-based double chemotherapy. And the last meta-analysis is for anti-PD-1 inhibitors. We evaluate 5 randomized phase 3 studies comparing anti-PD-1 inhibitors versus chemotherapy, including 2 studies with pembrolizumab versus chemotherapy and 2 with nivolumab versus chemotherapy. Next, please. And then we have the following results. First, we will see improved OS in female patients in data from the routine setting. In total, 7 studies for OS multivariate analysis were identified in meta-analysis with the random effects methods, and HR saying 0.73 was obtained in favoring female patients with the highest statistical heterogeneity between cohorts, with interval of confidence for 95%. This figure 1 meta-analysis of the effect of gender in the overall survival comparing HRS and 95% CE obtaining for multivariate analysis in hospital database. Results Results show that gender is a prognostic factor favoring female patients A, and the final plot show no publication bias among studies including in the analysis in the image B. No? Next, please. Effect of anti-EGFR TAKIs. In total, 931 female and 494 male patients were evaluated in 6 phase 3 trials. The meta-analysis in male patients showed an HR saying 0.44, favoring EGFR inhibitors. There was not observed significant heterogeneity between cohorts. When women were evaluated, the meta-analysis showed an HR saying 0.34 with high heterogeneity between cohorts. Next, please. Continue with anti-EGFR TAKIs. In the meta-analysis in the female cohort, there was observed a publication bias in the optimal study. In anti-PD-1 inhibitors, for all studies, 1,028 female and 1,435 male patients were evaluated. In male patients, it was observed an overall HR saying 0.76, favoring anti-PD-1 inhibitors with significant heterogeneity between studies. For female patients, there was no clear benefit seen from nivolumab or pembrolizumab when compared with chemotherapy, no? And there was no significant heterogeneity within the cohorts. Next, please. Anti-LK inhibitors is in 4 randomized phase 3 trials, 751 female and 536 male patients were evaluated. The meta-analysis resulted in the HR saying 0.48 for men, favoring LK inhibitors without heterogeneity between trials. No? Next, please. And finally, with results of anti-LK inhibitors, the analysis in the cohort of female patients showed an HR saying 0.51, favoring LK inhibitors. In this evaluation, there was no heterogeneity between trials. In addition, there was no observed publication bias. Next, please. Continue with the discussion. We have to, there is a well-known fact that women have better outcomes than men in several cancers. The risk of death for cancer is 1.6 times higher in male than in female patients. In the data, the meta-analysis with random effects shows a 27% reduction in the risk of death in female patients. 6 trials evaluating EGFR TAKIs showed a 10% reduction in the risk of progression. HR saying 0.44 versus 0.34 for men and women, respectively. In this analysis, because all patients have sensitizing mutation in EGFR, the treatment was given in the first line and the comparison group was chemotherapy. Next, please. The main bias is that several risk factors could have a different distribution between genders, and the evaluation of various cancers showed that only 15% of women have a higher mutational load in the contrast to male patients with 31.2%. Immunity promotes tumor progression, and since women have a different immune response than men, it could also shape a distinctive biology between the gardens, for example, a lower mutation burden. In a recent report evaluating patients with a melanoma, female gender was significantly associated with a lower likelihood of response to anti-PD-1 inhibitors. Next, please. And finally, we have the following conclusions, and we have four conclusions specifically. And the first point is this exploratory study, some strategy treatments were influenced by gender, despite difference in outcomes that could be attributed to different histology, EGFR, and smoking status. Gender should be evaluated more deeply as prognostic variable in patients with NSCLC. And the second point, precision medicine has put in the mind of oncologists to genomics as the axis of drugs prescription. However, there are classic prognostic variables that can be taken into consideration for precision medicine. Gender is one of the oldest prognostic variables in oncology that is being more and more time left behind in the current research. And finally, gender should be analyzed applied in current trials because biological difference could compromise response to targeted drugs. Next, thanks for attention.